Okay, but I'm not going to start all over. So let's move on. This slide was meant to be short. So yeah, dysarthria affects all those speech dimensions, but not in every patient to the same degree. And that is important. And we also know that we have different types of dysarthria. Now, these impacts on the speech functions lead to what, and we have talked about that already a lot these days, reduced speech intelligibility, and it can also have an impact on speech comprehensibility. Now, and we all know that when you have a speech disorder, whether it's a motor speech disorder or a speech disorder related to another condition, this has an impact on our patients' communicative participation. And related to that concept of communicative participation, there is also speech-related quality of life. Now, when we look at it's not moving. Yes. At the assessment in daily clinical care for participation, we mainly rely on patient-reported outcome measures. And like you have here, the dysarthria impact profile. And here that's a study about the French experience. Leen, my colleague, developed a couple of years ago the Spraak Handicap Index. It's a Dutch tool to measure the speech handicap index. And quite recently, we translated the communicative participation item bank, which was originally developed in English, and we validated it for Dutch. And we did that together with the colleagues of the Netherlands Cancer Institute. So what I want to make clear here is that also for that part of our assessment, we're still developing new tools, but we also focus a lot on cross-language and cross-population validation. So the CPEB is now validated both for motor speech disorders as for head and neck cancer patients. So, and I really think it's important that cross-population validations are important to give the instrument more credit and to facilitate actually clinical implementation. Now, when it comes to the assessment of speech functions and the activity level, there we really rely on auditory acoustic signal produced by the speaker. And that includes obviously all the compensatory behavior of the speaker, speaking louder, speaking slower. Either it's a learned or a taught compensatory behavior, or the patient is doing that spontaneously. When we talk about comprehensibility, then we also take this, the signal independent information with us. So it's about facial expressions, cues that you get from the environment, and so on. Now, about this assessment, historically, we do it perceptually and with pen and paper. That's no secret. Yeah? And for example, for the speech functions, I think the gold standard are still the 38 speech dimensions features defined by Darley, Aronson, and Brown about 50 years ago. But they do have an advantage, and they are, they are in Dutch here, but they do have an advantage. They are all defined and they can be used across different languages. Are there alternatives meanwhile? Yes, of course. There is the French dysarthria assessment developed by Pamela Enderby. It has also been translated to Dutch, I'm sure, but also to French, I think, and maybe other languages. And our colleagues from Nijmegen also a couple of years ago developed het Nederlandstalig dysarthrie onderzoek, which also offers an alternative to perceptually evaluate the dysarthric speech. Now, speech intelligibility, it's a hot topic these days. So I agree with the definition that intelligibility is about how well a speaker's acoustic signal can be accurately recovered by a listener. And I also agree with the fact that it's not just one single measure, and it's influenced by a lot of different factors. Now, what we actually need are standardized assessment tools. So you can judge intelligibility by a visual analog scale, but it's better to have a standardized tool so that you can reproduce your scores. And when I started my PhD, and that's already a long time ago, there were actually, I think I only put 2 here, but there was actually a long list of tests that were available for English speaking patients. But there was nothing for Dutch. Oh, sorry, this was not meant to be a pop-up, but okay, so in 2006, we developed what we call it NSVO, and later on we developed the NSVO actually measures phoneme intelligibility and allows us to do phonological error detection. When in 2012, we developed a brother or a sister of that instrument that allows us to assess sentence intelligibility. Now, just in between, because I often hear that these intelligibility assessments are time consuming for us, but it has to be said that these instruments just take about 10 to maximum 15 minutes and everything included. So of course it takes time, but it's also relative. And I think that you have to take that in mind too, when you're developing a tool, that it has to be very easy and accessible so that it takes actually even less time. So now, when we developed these instruments, our point of view was always we have to come as close as possible to the definition. So that means that it should only go about the acoustic signal. But it's very difficult when you're doing a perceptual evaluation to exclude all the influencing factors and all the biases. So that led us to that, to some actually artificial measures like semantically unpredictable sentences, nonsense words, and we also had to create a large database of test items. Nevertheless, we investigated the reliability of these instruments, and as you can see, this is the total score, the total intelligibility scores. The inter-rater agreement is very high, so what is not unimportant. But anyway, when we're looking at our perceptual evaluations, there will always be a bias. Some have reliability issues, others are okay for that aspect, but they do require human resources and we are expensive. It's also a question, a matter of accessibility, especially for those patients that you want to monitor over time. It's not a problem that the patient has to come once to your office, but if he has a progressive disease, or even if you want to monitor the effects of therapy, then it's very easy if you could do it with an automatic tool, home-based. So what is also the case is that when we're using those instruments, we are not always able to give the patient immediate feedback, which is obviously also interesting when we're talking about speech therapy. So we had to, I think I still find it an honor. We had an honor to work with the colleagues of the University of Ghent. And in 2009, we published the Dutch Intelligibility Assessment, which is a speech algorithm that allows us to measure what we measure with the NSVO, but then automatically, so phoneme intelligibility. And it was, as you can see, the correlation in the figure between the perceptual scores and the computer scores was very strong. So it is validated in a way, but we also have to admit that we didn't have a lot of patients with low intelligibility scores. And also it's just validated in only 60, and that's between brackets, because only 60 patients with dysarthria. mild to severe. We had all those patients in the database, but also just Dutch-speaking patients with dysarthria. So that's why it's nice to see that there is a follow-up. And one of the chances that we had is within the Assisto project, there was a chance to validate that same algorithm for head and neck cancer patients. So that's nice to see. And within the TAPAS project, there was also a work package where the colleagues of the Ghent University and UMC Utrecht worked together to also look to dive deeper into the DIA tool. Now, when I saw yesterday, all the presentations actually made me a little bit really happy and proud, because what you see here, just here in this group, is that there's moving a lot. There's a lot progress that's being made, and there are more algorithms that are developed to measure speech intelligibility, but also other aspects, phonological error detection, distortion, and so on. So that's nice to see. Then something completely else. When we move to speech therapy, I would like to spend some attention to articulation therapy, because improving articulatory skills is actually often the major goal of our treatment. And that's why is that? That's because impaired articulation is a hallmark of motor speech disorders, and it occurs in every type of motor speech disorders. Now, we can either approach articulation indirectly by suprasegmental approaches, where like speaking louder, or you can really target it directly. And then you are really going to try to make a change in the physiology. And that requires actually a lot of intensive exercises, and we call them drill exercises. You just let the patient repeat and repeat and repeat the target words one after another with feedback. Sometimes we also give them some information about articulatory placement. And what is important there is that we do a lot of modeling for the patient. Now, so it requires a high number of repetitions, a lot of therapy sessions, and home practice. It's not enough that the patients just to change behavior. It's not enough to practice once in a week with your speech therapist. You really have to do it continuously. So this is why a virtual articulation therapist, where a virtual articulation therapist could make a difference. Now, something more about the feedback. Feedback is important to change behavior. And for articulation, we can either give feedback about the result. Oh, it's better. Oh, it's good. Oh, no, this one was not so accurate. That's actually what we are all the time saying. It's, or we can go more into detail and give the patient information about his performance, about the phoneme features. And then it depends on what we hear or think we hear. Now, which type of feedback is the best? There's something where we certainly need more research. Hello? Yeah. But there are indications in literature that they are actually equally effective, so that it's not always better to give really detailed information to your patient to improve his speech. It can be enough to just tell him whether it's good or not. So then back to the possibilities for the automatic algorithms. For the first one, it's nice, and that's why we developed the algorithm for degree of distortion, because there was nothing like that. But it's nice to tell the patient how distorted his speech sound is. And it would be nice to be able to do it on a scale from 0 to 100 or 0 to 10. And as you have seen yesterday, the algorithm that we have now allows us to categorize the degree of distortion in 4 categories. So on the other hand, when you want to give feedback on the level of performance, then it's nice. Oh, sorry. Then the phonological error detection comes into place. And that's also one thing that we included in the virtual articulation therapist. Questions that are remaining is, and these are important, I think, how much feedback do we have to give the patient? How frequent? And what are the patient's preferences? It could be that some patients really prefer to have detailed feedback, and others are fine with just indications, whether it's good or not. And that's not only something for the tools or the algorithms, it's also a question for us as speech language pathologists. Now, one more thing I want to draw your attention to is adherence. Now, adherence is something multifactorial. It depends on the disease itself, on the treatment characteristics, on the patient characteristics, but it also it depends on the therapy characteristics. So what you are offering the patient. And what I'm going to show you is something completely different. These are the results of a study that we recently conducted in patients with head and neck cancer that are treated with chemoradiotherapy. It's a multicentric study, and where we looked at what we want to do is give these patients during therapy, during the radiotherapy, we want to give them preventive swallowing exercises. We know that these exercises can improve swallowing function and muscle strength, but a big problem is that patients are already in a burdensome period, and the adherence is sometimes very moderate to low. So what we did in this study is we compared whether a group of patients that practiced it at home with a diary, paper supported, versus a group that worked with an app that was specifically developed for this project, and then a therapist supported group. And what we did find, so we developed an app for this, which had clear instructions, demonstrations, push messages, and a gamification element. But what is important to take with us, I think, is that when we look at the percentages of adherence, that there was a significant effect between the groups. And as you can see, overall adherence was the highest in the group that practiced every day with the speech therapist. And actually, the group that practiced with the app had the lowest adherence. And that doesn't mean that it will always be like that with apps, but it's something that we have to take in mind, and we have to think about how we can make sure that patients actually do practice when they have an app. So, and that brings me to my last slide, if I still may. So what I think, or it's maybe a dream, but it's what would be nice, I think, is that we have within Europe just a standardized set of algorithms for the assessment and treatment of speech disorders, motor speech disorders, but speech disorders in general. And I think, maybe it's time that we can come to a consensus on what is a valid measurement. We probably have to compare the algorithms with each other for that. We need cross-population validations. We do need algorithms for detailed feedback. And what is important also is, I think, immediate feedback. It's not on my slide, but it's important for our patients to get, they do an exercise and they want to know immediately how well they did it. Valorization is probably very important. If you want, once the tool is there, you want to be to get it on the market and to stay there. And what is also important is, you're doing all great jobs developing algorithms, but it are the tools that we need to get to clinical implementation. And also importantly, we have to reduce, we all have to reduce the barriers for speech technology. And it are not just the barriers of the patients, it's also the barriers of the clinicians, because we do still like paper a lot. So, okay, and last point was maximizing the patient's adherence. So it's a full schedule. So Matthew, that was why I'm thinking this, for me, this could be TAPAS point 2. So a full project. Okay, but thank you. Can I? What do you want me to do, Matthew? Just move on. Daniel. Yes. Okay. So we start now with Daniel, or not? Or we- Yes. Oh, ich wollte so ein- Yes. Maria, are you
Yeah,
online? Okay.
yeah, I'm online. All right. Hi, everyone. Good
Okay.
morning.
Welcome. Okay,
Should I?
so we move on with Professor Maria Schuster's presentation on the care of for persons with hearing impairment, new methods for speech evaluation and rehabilitation.
All right. Should I? You see my screen? Yeah. Seems so.
Yes.
Okay. Just let me see myself.
Are you
Sorry.
sharing simultaneously? I was sharing your slides too. Wait.
Yeah, I don't know what that's which one is better, but you see it, and I just let me see if I no, can't do anything. Just let me try again. Then it's visible. Yeah, okay, I can see it's visible. So
Yes.
thanks a lot for, yeah, sorry that I can't be with you. You hearing me?
Sorry, we're struggling a bit.
All right. So just let me take the time now to congratulate all the ESRs. So I really had the pleasure to hear a lot of really nice presentation talks. Was gorgeous. Thank you a lot. So it's great achievements in the TAPAS project. I just want to go into another topic with the hearing impaired, and that's the topic of my project. And Tomas Arias Vergara was the one who was doing a really great job on evaluation, new methods, developing and seeing whether they work and making some progresses on it. So just going to the topic. So hearing impairment becomes a really growing problem. And the World Health Organization is saying that about 5% of the world's population suffering hearing impairment, or not always suffering, but living with hearing impairment. And that means that about 1.5 billion people globally live with hearing impairment, and it might be a growing number, not only because we have more noise around us and the hearing is getting worse by acoustic overstimulation, but as we're growing older, also the amount of people who have a hearing impairment is growing. So that makes about 170,000 to 200,000 cochlear implantations per year in the USA alone. So worldwide, there's no exact data how many, but there's some companies that really do a great job with developing and serving those implants, and it's emerging field of technology, and they're living quite well by this technology. So it's something that's growing and growing. So for my company, the Ludwig Maximilians University at Munich, we have about 120 to 170 implantations per year, and 1 year or 2 years, but that sums up to about to several thousand people we're going to see over the years, of course, and that's not a small part of all the patients we have in the clinic per day. The history of cochlear implantation is something of a big success. So it began in the 1978 with a small device implanted that got 2 channels, and that really only provided a degraded signal. But if you're deaf, you're just glad to hear anything. And if you can't understand, at least you hear something. So but nowadays, if you implant a child that's been born deaf, in the first month of their life, they can develop normal speech. So you can't really hear that there's a difference, and of course, the first time with a small delay, but it's something of a huge success, and that's the only device an active device you can implant that really provides a good function. So for instance, for vision or smelling or things, they're just developing something, but it's far from being as good as the cochlear implants. Cochlear implants is something you use only when hearing aids are not sufficient anymore. So it's mostly in severe to profound hearing loss. And but then it usually works good if it's done early enough. But then the implantee needs a lifelong follow-up. So you have an implant inside your head, and of course you need to test for the function. And there are some updates, of course, for the speech processor. You have on the outside of the head, and the implant itself, it stays for years or decades. So the first implantee of the Munich clinic, it was implantation was 39 years ago. So it's still inside and it's still working. So the implant stays, but the outside thing, the speech processor is changing. So of course you need your follow-up, and the main outcome parameter, of course, is the gain or the percentage of speech understanding. So just let me have a small way around to the main topics. That's how do we describe a medical condition? And we heard a lot of our speech, and of course we medical doctors, we like numbers. We like numbers and graphs to see what the status of the patient, and is it good or not good, and how good is it, and then we compare it. And the numbers give us, of course, the information if we need to do something or not. For instance, with blood pressure, if it's a 200 to 100, of course you need to do something. If you take a medication then and it's going down to 160 to 100, say, it's better, but not good enough. So you take another medication. So we really count on numbers and comparison of the status before therapy and after therapy. To see whether therapy is working, we also need, of course, medical research, and it's also counting on numbers. So now you need the number for the reliable study results. You need some objective data. We talked about the word objective yesterday, but just call it objective. So the thing is, for speech of the hearing impaired, it's something that it's not really well examined. There is a number of examinations that it's done for the last years. So before the area of cochlear implants, mostly on speech of the deaf, and vowels were highly examined, and of course some consonant thing, but always with perceptual means or with acoustic means. And it's of course then topic of new outcome evaluations. And just as we do it for the hearing impairment. So for hearing, just let me take you in this topic for a small time. If we examine hearing, it's always a combination of different methods. So in the end, we have really multidimensional assessment of hearing, and we can say about the quality of hearing, what kind of hearing loss we have. Is it conductive, or is it the inner ear, or is it hearing nerve? And we could tell about the extent of the hearing loss. And we have this combination of the psychoacoustic measurements. That means the patient has to contribute to the measurement. And then we measure the hearing threshold along the different frequencies that are necessary for understanding speech. Or we can measure how good do they understand speech, and that's done with the standardized speech materials or single words. In this case, as a standard, as a certain sound pressure level, and then you can measure how many of these words did they understand in percentage. You can do that in quiet or in noise, and then you might have some acoustic measurements, for instance, the autoacoustic emissions that give you information about the inner ear function, or some electrophysiologic measurements like the IRR. So it's kind of EEG, and you put some noise on some standardized and of course well-defined acoustic signal on the ears, and then you can measure the procedures on the hearing nerve and the brain. And that's something that's really giving me good information about the hearing status. So for speech at the present time, there's no such things that give me this multidimensional information about the status of the speech. And it's also because, like we were told before, so it's time consuming, and the tools to assess speech, they are not really standardized, and especially for the hearing impaired, you don't know where to look at. And so usually we just do a perceptual evaluation about the articulatory precision, or more or less about the articulation errors, and just have a small hear about the differences. I'm not sure whether that's possible. We'll just try. You hear that? So it's something that's not normal, but it's not that deviated either. So that they would say mode is something that sounds quite natural, but not totally.
Maria, we don't hear it loudly.
All right, so I'm going to go on. So, so what I wanted to say is that the deviations
Wait,
of
Maria,
speech...
I can put the volume a little bit higher. Wait.
Maya, when you're sharing the slides, you can unshare and share it again. And in the bottom down there will be an audio sharing option when you're sharing the, the slide. And then everybody can hear what you're playing there. You just have to unshare, and once you share, when you're sharing, just see on the bottom left, you will find a small button to click share audio there.
Yeah, I would like to see that. So okay. We just skip it. So don't worry about that.
Okay. Thanks.
Yeah. Yeah, sorry. So just continue. So what we know about the speech of the hearing impaired, that they have some articulatory precision problems, nasalities affected, voice, suprasegmental features, and intelligibility is affected. About breathing, so I haven't seen anything yet, but just have a look later into rhythm, for instance. So everything is nicely shown in the Gautam article, for instance, and they show all the newest or latest articles, publications that are done about that. So we started about looking into speech quality some years ago, and the first publication about that was done with the ASR, which just looked into quality measuring automatic speech recognition rate on words, single words. And we have seen that we have some groups that are differing. So for Thomas just told you about it before. So the prelingual deaf patients, they perform differently from the postlinguals. That means prelingual, they never experience normal auditory feedback. So they never heard properly. So it was always done by a hearing aid or then by cochlear implant. And as the cochlear implant doesn't provide a full frequency range or resolution, of course, the acoustic signal you get is always not normal. So, but nevertheless, as I told you before, children, they might perform properly. So in former times, we waited a long time until the children who were deaf or had hearing loss were provided with a cochlear implant. So all these children who are now adults, they had their cochlear implant rather lately, and therefore they had a huge delay in saying better speech development because they haven't heard it before. So when we look into the speech data of them now, the prelinguals, they perform much worse than the control group, the age-matched control group. And seeing for those with the postlingual hearing loss and who had a short period of deafness, they perform just like those peers at the same age. But if you wait a long time until the cochlear implantation is performed, speech is degrading. So those postlinguals who were deaf for a long time, not provided with sufficient hearing amplifying, they lost their ability to perform normal speech quality, just let it say this way. So, but what we achieved in the TAPAS project. So we just introduced some new reproducible, not objective, but reproducible evaluations of speech regarding segmental and suprasegmental aspects and also breathing and rhythm. So for instance, phoneme posterior probabilities, Thomas just presented this yesterday. We can measure how good the articulatory precision is, or just to get some information about voice and articulatory precision, we can measure the onset transitions and offset transitions. And of course, we see some differences in between these groups. And just have a look at this nice graph, you know, these, and it's nice for the medical doctor if you have a graph like that, and you immediately can see whether there's a difference, or for instance, if you take it at the longitudinal evaluation of a patient, you can see the progress immediately. That's nice to have, and it's something, yeah, we really like. There would be nice to have the numbers too, of course, but if you see it on the graph, that's perfect for the clinical implementation. So of course, we can look into other things, like we looked into the prosody, and this was done for spoken text, but a read text, not spontaneous speech. The things before, the articulatory precision, were done on words only. And we see that there are differences. It's just an example of the newest work we just submitted and was accepted. And we see differences in between the cochlear implant users and the controls. And that's something that's rather great, because I ever said that, yeah, there is a difference. I can hear the difference, but I really can't name the difference. I can't say with my words where the difference is. I can tell there's another rhythm, or I think that the vowel timing or voice ratio is quite different, but I can't really say measure it. So with the methods we applied, we can do that now, and it just gives me good feedback about what's happening, what's different. And I think the long term, if we just measure it in the longitudinal way on the one patient, showing them how it is and showing them how the progress is going on in the course of time. That will be a nice, really nice tool, like Gwen said before. That's something the patient and also we clinicians, we are really going to profit from. So of course we can show the individual changes too. And Thomas said that the longitudinal study was something that was quite not really successful, but we just started with the project and then we stopped for the recording because most of our patients with a cochlear implant, they're not ill. So if not necessary, they don't go to the clinic. So they don't come for the recordings. And we had a huge seizure of the recordings. So the longitudinal study was quite not really successful. And we stopped and have only these data on the different groups. So what we need to do, and we had something about challenges, of course, and I totally agree with Timothy, who told something about standardization and how could we measure it, and saying we really measure the right thing and we really have the right interpretation. We need the standardization. We need the same recording settings, for instance. So it was really a huge topic at the beginning, because how do you place, or what kind of microphone do you take for the cochlear implantation people? Though you can't put in a head for closed talk microphone because they have two devices on their head. You can't put anything on top. So which microphone do you take, and how do you prefer all the settings of the recording, and which method do you take for the evaluation? And then we thought about combining speech perception tests, so these words to repeat, and with the recordings, but then you have those things with the firewall at the clinic, and you can't put any other tools on those clinic computers. So and at least you need someone to do it. And then of course for the clinician it would be nice to have a threshold, say this is quite normal and this is something that might be caused by the hearing disorder. And that of course this needs to be done with respect to age, gender and dialect, and that's why we need a huge amount of recordings and to compare with. And in the best way in the same language, or looking into dialect differences, of course. And then of course we need to identify which speech material, which speech task would be the best to really see for differences. So at the moment we are just using a task that consists of single words, of a spoken text, of some free speech, some sentences to speak with regard to nasality and voice, and the pataka, of course, and that takes about, if you're quick, 7 to 10 minutes to record. And some of the patients do it themselves. You just put them in front of the computer and say, just click here, and the program is working. But of course, it would be nice to have something quicker, just to implement it into the clinical routine, and afterwards to have the exact changes from the first meeting of the patients to the next and the next. So we need to see which task, which speech material would be best to really track for speech changes. And then of course, who is going to do it? And of course, who is going to pay for it? So as an outlook, so it's nice that we see that it's possible to see for the individual and group dependent outcome examinations with numeric and graphical representation of speech of the cochlear implant users. So we like to do, of course, the long-term evaluations with regard to the hearing progress, or with regard to the hearing loss patients presented themselves with. And then if we see for these differences, then we can adapt some rehabilitation strategies, maybe on the individual or on the group dependent level. For instance, if you see that, like Thomas showed before, that mostly those phonemes that are not visible are affected, that you might train them especially. That's something simple, but of course you might also perform some changes on the algorithm you have in the speech processor, meaning that you can provide a better speech or better auditory information for the patients in order to increase the auditory feedback. And we like to do it, of course, with children's speech. You saw the presentation of Coach Leah, which is quite nice, but the beginning of a more of a wider project, seeing for the speech material, the pictures and so on. And of course, we need to be sure that it's something that goes along with the patient security, with data security. And but it's a really nice way to work, because what we achieved in these last month is something that's really gorgeous, and I am really proud and say that we did a lot, and it's fine, and we can identify things, and we can even support patients with some speech therapies by apps. Last thing I wanted to say is that the research on the follows of hearing impairment is not only important for my study here, but of course, hearing impairment, as I showed you at the beginning, is something that is a growing topic. And if we deal with patients with speech disorders, we need to also take into account that most of our older patients might also suffer some hearing impairment. So if we see those differences, which is caused by hearing, we might also tell later on if dysarthria is only dysarthria, motor control, or if it's also a mixed strain between motor control problems and hearing disorders. So it's, of course, it's worth looking more into these into hearing disorders, and they follow on speech. And then thank you for your kind attention. And I want to again thank Thomas. He did a really great job. It was gorgeous, and he just finished his PhD some weeks ago with a degree, with a summa cum laude. That's really fine. Thank you for your attention.
Thank you, Maria. Yes, the questions are for later. And we are going to make a small change in the program, and I'm happy to announce now Dr. Daniel Blackburn, who's going to talk about the challenges in developing an automated assessment in ethnic minority groups. So, yes, you're already sharing your screen. Yes.
You can see me?
Yes. But small.
Can...
Your slides are not in presentation mode. Yes.
Okay. Can you see the screen now, and can you hear me?
Yes, perfect. Thank you.
Lovely. So thank you very much for inviting me to speak today. And I'm sorry I can't be in Antwerp, which is a great city. So I'm going to talk about the challenges of developing an automated assessment of cognition based on language, making sure that it's suitable for all of the population. So I'm sort of co-lead for CogniSpeak, which with Heidi Christensen from Computer Science, who many of you will know, and TherapyBox are our commercial partner. We've got clinical input, but I'm going to talk mainly in this talk about our stakeholder engagement, public patient involvement. So Lisa Sprosen works for an organization called Devices for Dignity. Professor Adi Adibajo is our EDI lead, and Ismail Youssef is from the community Somali group called ISRAC, which we'll speak to. So we all know what the problem is. If for memory pathways in particular, with an aging population, more and more people are developing cognitive impairment of multiple etiologies, including neurodegeneration. When they go to their GPs, there's often a long wait, and the GPs don't have the time or the necessary skills or the tools required to sort of do the proper assessment. So we do these pen and paper tests, and then there's significant waits before seeing a specialist. So if we could accurately stratify people at that primary care level, people who've got no evidence, and potentially we could keep them in primary care and then stratify more accurately the people coming. So that's what CogniSpeak is. This a digital doctor asks questions that someone like me would ask in clinic, and using automatic speech recognition to measure their cognitive level. So clearly this isn't just a European problem. and the increase in rates of dementia is going to be higher in populations where the population is going to age more quickly. So for example, in sub-Saharan Africa, there's going to be a near on 300% increase in rates of dementia by 2050. And the UK, like much of Europe, has a net influx of migration of people from non-EU citizens. So this is just a chart showing, the hundreds of thousands of people coming to UK from non-EU areas due to economic, social, political instability. So there are known biases already in our assessment, so that Black men in the UK developing dementia were less likely than white men to receive a diagnosis of dementia. And there's a lower incidence of dementia diagnosis in Asian ethnic groups in the UK. And from this paper, it's uncertain whether this is due to there truly is a decreased incidence, or there are certain barriers of people coming to the memory clinic. And these barriers are known, so that for many populations, the dementia may be thought of as just normal aging. So people think there is no need to come to a clinic, and therefore may not receive the sort of support that they can have in carers and other things to help support them. There's often a stigma around the diagnosis, so that translations of dementia in Somali and in other languages often refers to mental illness or insanity, and therefore it's not a diagnosis that's well received or that people want to sort of seek getting. There's also a lack of professional training for doctors to make sure that we don't permit bias in our assessments. Most of the cognitive testing were essentially designed on white people in North America or Europe. So we have collaborated with ISRAC. So this is a picture of their vestry hall, which is just on the outskirts of Sheffield city centre, with Adam Youssef, their chair, and Isma Youssef, their financial manager. And for this study, we've employed some research champions, Sarah and Musa. This is the photo of me outside them with Sarah and Musa, and Lisa from Device of Dignity, and April on the far right, who was a research associate working with us. So the Montreal cognitive assessment is shown here. In the bottom left, the English variation, the top left in Danish, and on the right, Swahili, just for an example. This is quite a stringent test, so to be scored normally, you've got to score 26 or above out of 30. And you can see the three animals used is the same for all of these mocha translations. And we found in the Somali population, many people didn't recognize the rhinoceros. There's no rhinoceroses in Somalia. And so therefore they immediately get this wrong. Of the 5 words that you repeat, so in English, it is face, velvet, church, daisy, red. In Swahili, it was train, chair, seat, hat, and blue. And we did some work in Nairobi. That's why I was showing the Swahili version. And they said to us, there's only one train in Kenya that connects Nairobi to Mombasa. So it's not a common thing that people are going to use a train. So why this wasn't as a bus, there are these other examples. There is a sentence repetition. I only know that John is the one to help today, which you have to respond completely correctly to get 1 mark. And people who don't speak English as the first language struggle with this, as we found with our Somali population. So we wanted to look at some alternative screening tests. So this is the RUDAS, the Roland Universal Dementia Assessment Scale, which is a multicultural test. So the word recall is tea, cooking oil, egg, and soap, which is much more acceptable and understandable. With our Somali population, when you use the word velvet, they didn't know what that was, and they have far fewer words for flour. There's a bit about judgment, about how you cross a road, and the fluency task in the Roland is animal fluency, as opposed to the mocha when it is producing as many F words as you can in 1 minute, which is a harder task, and a task of frontal lobe rather than temporal lobe. And there's also a test called the multicultural examination that Runa Nielsen created in Copenhagen, which has been validated in European populations. The word item to recall is 10 items that you show them, but you allow them to create the word. So if they call the top right image a tortoise or a turtle, a turtle or a tortoise, it doesn't matter. It's whatever word they're acceptable with. And similarly, the bottom right, if it's a dustbin, a bin, a bucket, as long as they can recall the word that they call it, that's fine. And the fluency task in this is producing as many words as they can that they could buy from a supermarket. And so it's important to tell them beforehand that what a supermarket is, because it varies. So, you know, the large supermarkets often sell clothing as well as food products. So that's fine as long as they know what they're buying and this is what they do in real life. So we, in the first stage with Sarah and Musa, we wanted them to let us know how to contact people from the Somali population, but we wanted to train them in using the technology, but also training them in using the Montreal Cognitive Assessment, the RUDAS, and the MCE. So the control person in here is Caleb, who was a master's student, and researcher one is either Musa or Sarah. And you can see there is similarities between their scores, but also significant differences. And I think important in the mocker, with Caleb, 9 out of 10 people scored below the cutoff, as opposed to on the RUDAS when it was 0 out of 11 scored below the cutoff, and in the MCE 1 scored below the cutoff, showing that those are probably more acceptable tools. And it's likely that these people have a degree of anxiety when they come in to see us, that if they score below a cutoff, although we wouldn't use this to make a diagnosis, these aren't diagnostic tests, the stringency of the mocker just doesn't give us a fair reflection of their cognitive abilities. So this is Research Champion 2. The thing we need to look at is that we give people vouchers to come and take part, but sometimes you have to go home and come back. And Caleb noticed that like halfway through the assessment, people word of mouth were telling people what to look out for. So therefore people started to know what a rhinoceros was. And there's a learning effect from doing this test from the first and second time. So we need to work out the timing and whether we give people a dummy run with one of these tests, and then so they get used to sort of what the sort of testing is going to be like before we use it in real life. So we think we've learned quite a lot. We think Sarah and Musa have been really helpful here. There was anxiety about the people coming in. They think they're going to get tested for dementia, and the feedback from Sarah and Musa is that some people find it really interesting and want to do more of these sorts of tests at home. Some of them think, oh, I scored terribly, I need to go and see my doctor about this. There's something wrong with my brain and memory. So we need to have some clear delivery beforehand, explaining what the tests are and what they are not, and also potentially giving them some feedback after the results and letting them know where they are. There was some preference that some of them would rather work or do the test with Caleb, because the community, although quite a Somali population is quite large in Sheffield, it's still a close-knit community. So that although the researchers are keeping it confidential, as I felt they'd rather do it with a stranger than somebody from their own community. And we're going to explore the effects of education, age, and exposure. In terms of how we're going to recruit people to the main study, because we've just got the new version of Cognospeak ready, we've created a video with Musa, or rather Sarah, and me speaking to camera with Somali subtitles that was done in-house by Yesin, who works from their multimedia group. And all the extra work we do with them just increases their trust with us, because you know these communities often felt marginalized and underfunded. So it's taken us, you know, a year and a half at least to do all this working with them. And I think it's really important that we look to see how we can recruit people with cognitive symptoms as well as healthy control. So John Dixon is the primary care lead within the study, and we can now look for different ethnic populations of East African origin and areas of deprivation to make sure we try and be as inclusive as possible in our study. So this is it's a big group working in different areas. I've spoken about the PPI engagement, and I'd like to thank Runa Nilsson from Copenhagen, who's joined us to give us advice, and Khatija Khan is another neuropsychologist based in Trinidad who's advising us about this. So thank you very much for your time.
Thank you, Daniel, for this nice overview. We have to continue, and I will also announce we will have lunch at 12:15, so that will mean that some presentations will move to the afternoon session. Okay, and then our next speaker is Virginie Wazar. Virginie, are you there?
Yes, I'm there.
Okay, can you please share your slides with us?
Yes, sure. It's a pleasure to be with you, and I record my presentation to avoid matter with some flux. With some flux. So I'm sharing with you at the time. Is it okay for you?
Yes, we can see it perfectly. Thank you. Please go ahead, Virginie.
Universitaire des Cancers de Toulouse. Do you hear? In the University Hospital of Toulouse.
Wait.
I'm talking about future perspective in automatic assessment of speech
Yes.
disorder in oral and oropharyngeal cancer. The framework of perspective for me as clinician and most important as phoniatrician is to improve quality of life of my patient. It's why in my experience now, it's very important to make the link with the improvement of the quality of life and the prediction of the impact of quality of life from expected functional impairment. Because the main questions for me are how to reduce the production of impairments and how could it be remedied. And if reduction of the production of impairment is linked with the prediction of the impact of quality of life, how could it be remedied is most linked with the improvement of the quality of life. For that, the conceptual model I'm using is the model of Wilson and Cleary model, because there is a focusing part of biological and physiological variable translate by the symptom status, and after that we upgrade the dimension, including characteristic of individuals and characteristics of environment to appreciate functional status and health-related quality of life. Now I will be focusing on intelligibility measurement. In fact, with the experience of TAPAS, we know that we have now a lot of algorithms giving a measurement of intelligibility, and we have few automatic tools helping to identify and or quantify speech impairment. But there is a lack of reliability, a lack of sensibility to change, and we have matter with the fact that we need to have a clinical significance of the measures, and we need to have easily way to capture the speech and the voice of the patient. And the big matter is also the recording condition. We are not able in oncologic practice to put the patient in a very strict condition for having very, very good recordings. The other fact is that we feel that there is specificity of the algorithm regarding the types of disease, and in our situation, the type of tumors and perhaps the type of treatment. And so we don't know if our algorithms are able to be used more more widely. Therefore, regarding the perspective, we are going to complete our corpus for being able to analyze the performance of the algorithms by tumors localization and by type of treatments. And for that, we create a scientific interest group that is a parallel-tech, and we are increasing the number of recordings of several kinds of patients. Moreover, we need to work of the clinical significance of the measures, and for that, Julien Mauclair suggests to me that we need to have a more circular interaction and relationship between researcher and clinician, because she said that researcher can find some outcomes that what clinicians are not understanding, but maybe it will be interesting to study this outcome for increasing our knowledge as clinician and researcher. More important is the integration of other functions, because in oncology, as in neurologic disease, patients have several deficits, and there is a link between the deficits And for that, I invite you to listen to read a very interesting special issue about integrative neuronal system underlying vital and digestive tract function. And in practice, yes, it's very frequent that we have breath sounds on the signal. We have saliva management, aspiration or oral aspiration or aspiration in the lungs, and the patients need to protect the lungs. So there is some noise in the signal, alteration of prosody, linguistic facts, and compensation at the low or also high level of language. We in our perspective, we are working about automatic identification of different throat zones in healthy subjects and in several diseases, and that we are working on the concept of pharyngeal laryngeal effectiveness. That is a project with the grant of the Agence Nationale de la Recherche in France, and in collaboration with a company making a multi-sensor captors device. And to end, the quality of life. That's a big challenge. And the question is, can we assess communication impairment and quality of life by automatic analysis speech? That is the work of Mathieu Balaguer. Mathieu Balaguer makes a very, very good thesis. And the title was Measuring Communication Impairment by Automatic Analysis and Spontaneous Speech After Treatment for Oral and Oropharyngeal Cancer. He made a very interesting work because he performs some semi-structured interviews, and with automatic tools, he explores the whole level of communications, linguistic communications, at the level of articulation and the level of categorical production and conceptual production. And for that, he analyzed, I don't explain to you all the work that's urged, but you have here, so in French, the main automatic tools he use anti-scopus. And moreover, he add to this as automatic assessment the intermediate factor that it not focusing on speech, that are not focusing on speech. So the result is that he was able to correlate the automatic measurement with a communication score, very at a good level and a good reliability. What was surprising is that this communication score is most correlated with very low level of linguistic units. That it's occlusive. The number of occlusive that was recognized and the number of sounds recognized, and it's linked with the fact that the speech recognition for the word was very bad, and we hope that increasing the quality of speech recognition, we can go further in the correlation with quality of life, and not only with an intermediate measurement that it's the communication score. For this point, I will focus the perspective of the use and the interest of using spontaneous speech to look at the whole linguistic dimension, and to add for having a quality of life and not an intermediate on communication about an intermediate factors. And again, we are going to use for that the parallotech. So in summary, I will just say that we are going to follow the research with the parallotech. That is really an interesting data bank for speech, specifically for oncologic patients. So thank you very much for your attention.
Thank you, Virginie. It was a big warm applause for you. Thank you for sharing all your knowledge with us. And we have to move on. I'm looking for my papers here because the next presentation is from Kurt Schigo, I think, yes. Yeah. It's also just taking time.
So thank you very much, Kurt Schigo from Medical University Vienna. In this presentation, I just give you a very brief example of a current study we performed together with colleagues from the TAPAS consortium. In the first view, it might sound strange or funny for you. Nevertheless, it's a very important treatment. I'm talking about lip augmentation for aesthetical reasons. So lip contouring, lip augmentation. I think for most of us, it's a little bit strange and not familiar, but in the market, in the global market, this is among the most frequent aesthetic treatments requested. I'm not only a researcher at the university, I'm also practicing as a plastic surgeon in a small country in Carinthia in the south of Austria. So I do it every day when I'm in my private practice. It's really requested very, very frequently. And as it is so frequent, it's relevant in the medical field. And the question is, does it affect speech? I mean, we know, and we of course have to inform the patients about potential complications, bleedings, hematoma, even tissue necrosis if it's a severe complication. But never ever we are able to answer the question seriously and based on profound studies, is there any effect or affection of the speech quality after filling the lips? You don't find anything in the literature. And so we have done this. We did recordings before and after this treatment and utilized all the tools and the environment from the TAPAS consortium. It's from Julian Fritsch and Matthew Doss at IDEAB Institute to analyze whether there is anything detectable. This is an example, and just by chance, yesterday in the Courier, this is a very important and fast spread newspaper and a daily newspaper in Austria. You see a very beautiful example. I mean, not to my opinion, but for my taste, it's a little bit too much. I always tell the patients sometimes less is more. So I would not have done this. However, it's just yesterday in the Courier, it's a very well-known daily newspaper in Austria, and they say, okay, what can you think of lips that look like inflatable boats? And this is, of course, what we want to avoid. But if we do it correctly and not like this, this is what I do in my private practice. You know, the aging process leads to a loss of volume in the lips, not just in the lips, but in this case, we are talking about the lips. And if I do it moderately, just to send my approach and my opinion and also inform the patients, is it's well done when you don't recognize it. So if you do a beauty treatment, can it be a facelift or whatever, hair transplant surgery, whatever you think of, and patients say, oh, well, it's well done, nice operation you had, nice treatment you had, then it's not nice. It's not a good success. It's a good success when you don't recognize that something has been modified. So in this case, it's just 1 milliliter, and we just emphasize the natural shape and we correct the volume loss. Here, the aging lip has some volume loss, and with 1 milliliter hyaluronic acid filler, we can improve it, particularly in the profile, you can see it. So there are many, many products available on the market. It's more or less the same. I prefer products that are combined with lidocaine as a local anesthetic, so this makes it quite comfortable for the patients. And in this study, it has been approved by the Ethical Committee of Vienna. Just to mention, I have not done it inside our university hospital because I don't want to occupy resources in a public hospital that is for treatment of patients for aesthetic intervention. So we did it in a private practice with a colleague, Dr. Wegostek in Vienna, very famous beauty doc, and her daughter, she is a plastic surgeon. And we included 11 women in this pilot study, and the colleagues from IDEA, Julian and Mathieu, gave us a standard text with different criteria. I'm not an expert in speech analysis, but it's something that doesn't make sense for many, or for normal people who are not familiar with literature, in order to detect differences. And we also asked them to read the 5 pairs of words, and we recorded this. And after the analysis, I don't want to go into details. You find the PowerPoint on the platform then, because on the one hand we have limited time, and on the other hand I am not able to give you all the profound details of the methodology. I'm not the speech expert, so this can be answered by Julian, who has done the evaluation then. But however, we did it in 2 ways. One was a special standard test, and the other thing was an automaticized test. And with these methods, and I again emphasize, it's the first time that it has been done this seriously, and this with this sophisticated, let's call it sophisticated methodology, we could demonstrate and prove that there is no observable difference between before and after lip filler treatment. This is very important. So actually, we normally do not recognize this, but however, it's the first time in medicine that it is actually proven by a study. Here are the details of the results, and also the other testing approach, the other testing methodology demonstrated that there is no observable, in some details in theoretical differences, but no observable differences before and after the application of the filler. So actually, this is the first time we could demonstrate this, and I'll just keep this short. Thank you for your attention.
Thank you, Kurt. Okay, our next presenter is Dr. Rob van Zon. Rob. This one. Yes. Okay. Please.
Thank you. Still good morning, all. So, most of what I wanted to tell has already been told in very much detail. So, I will keep it more practical. So, when asked to tell something about what our perspective is, I thought, let's ask the people doing the actual work. So I conferred to my colleagues who are a speech and language pathologists, and next to all their marvelous research, together with Gwen, partially, also treat our patients and have followed what we did in TAPAS quite closely. So now, we work at a head and neck cancer department, where we do treat people with radiotherapy and surgery. I'm mostly in the surgery part, but that is not really important here. And head and neck cancer is many cancers in many areas with many effects that can be quite different. And as our involvement in this in TAPAS was about oral cancer, this is cancer in the oral cavity, I will limit myself here to keep it within time. So oral cancer is a very aggressive cancer. not treated, you die quite fast. And it has a very aggressive treatment, especially if you have the larger tumors. If you're quite a little bit late, the treatment is really aggressive, and it changes your anatomy and the physiology of your oral cavity, and also all kind of neurological parts. So your tongue and jaw and so are really changed. And if you're not operated, you get radiation therapy, and that changes the physiology so much that although it doesn't look like it, your tongue is not the same anymore. So this can lead to change in speech and voice and swallowing. I will limit myself to speech and voice. Some people, you don't hear anything. They report, yeah, I'm tiring. I tire more easily than in the past. I can't speak that long and I feel different. But if you meet them in the street, you don't hear much unless you are a speech and language pathologist. However, it can be severe, very severe. The symptoms are like lisping, is very often reported, slurred speech, vowel space can be reduced. Often the E and U part of the vowel space is reduced. Nasality can be affected if you have if the tumor affects the soft palate. Problems with voice, because you think it's the oral cavity, but radiation therapy has no sharp boundaries, so your throat can be affected, the larynx can be affected, and you can have reduced intelligibility up to total unintelligible speech. I have an example just to let you know what can be happening. This is an extreme case, which you can't hear. No, it's like dysarthria, but somewhat worse. Nothing happens. Yeah. So what does a speech therapist do at our department? We split it in two. We have counseling before the treatment. Patients come in before treatment, and they get the speech therapists determine the nature and the severity of the changes and effects on patient life expected from the chosen treatment, and they discuss this with the patient to prepare them. Even like what Gwen told, you can have training beforehand to get more strength, to strengthen some of the muscles that might be affected. And we want to inform the patients about the likely nature and the severity of the outcomes. Because if you have the wrong expectations as a patient, that affects your the way you can cope with the outcome of treatment. If you know what's awaiting you, that helps a little bit in the anxiety and a lot in coping with what's coming. Then after treatment, there's the therapy, the actual therapy where we try to, or the speech therapists try to improve the articulatory function and in general impact on daily life and whatever, how to cope with quality of life aspect. And it's not just articulatory training, it is also adapting your speech to your abilities. A famous case, but in our case is a woman who lost all of her tongue. So her total glossectomy, she got a flap, like a part of her arm or leg, I'm not sure, was put in her mouth and to fill it up. So you say language is a tongue thing, so you can't speak. She could speak. She even gave horses. She's a kind of horse, not really a horse whisperer, I think, but something like that. She gives courses for people with horses, But yeah, you can't make all vowel or all phonemes anymore. So she adapted, she switched words. She can't say kracht, it's Dutch, so you say power. That's all labials. So that kind of thing that was, yeah, it seems to be staple in speech therapy. So that's the thing we can do. So what is the approach in assessing the speech and assessing the patient? So that's what TAPAS is about. So Gwen already told you the first two patient-reported outcomes and perceptual evaluation. That's the standard practice, and there are tools for that, mainly pen and paper, pencil and paper. And next step is automating some of these perceptual tests, like the intelligibility test was already discussed several times. Grading can be done, like there are automatic gradings for voice. Developed here in Belgium, the AVQI, that's quite good. So good we don't do grading by the SLPs anymore, because yeah, that's a waste of time. The thing works just as good. But we want to computerize more, everything. And then obviously nice tools, because yeah, the AVQI, it's not that easy to apply and cost time and so on. The next thing is, so we are talking about speech. We feed speech into computer programs, and they give us all kinds of information about the articulators and the movement of the articulators. But we would rather look at the articulators themselves, because speech is indirect and complex and affected by everything and this phase of the moon. So we would like to do articulatory evaluation, not only in speech, also in swallowing, because tongue movements are what makes swallowing and what breaks swallowing. So in the past, there was people were fond of X-rays and they used X-ray movies. People are have become much less fond of X-rays and radiation. So that is fallen out of favor. We still have video fluoroscopy, and that can be used a little bit like that, but that's not ideal. What's coming up into fashion is movies with MRI. MRIs are coming better and better, and you can do more and more, and you can now even generate movies like 20-25 frames per second for fun. So you can now actually do recordings of articulations. However, MRIs are not plentiful, cumbersome, and used for more important things than looking how your tongue moves. So that is interesting in a scientific way, but not actually for your run-of-the-mill common speech therapist to use. It requires a lot. So the next best thing is articulography recordings, where you put sensors on the tongue and follow them and see how they change. Sensors are not ideal. Sticking things on tongues is not ideal, and it changes your speech. But anyhow, it's a way to look to see what's happening. So first, we go on somewhat deeper into the objective acoustic evaluation. Yeah, the details, half of you or 3/4 of you can tell me all the details about how this works better than I even understand it. So I won't go in there. But on the outcome, we would like to have severity evaluation, all the dimensions, as Virginie also discussed. We want to have intelligibility measurements, as has been discussed into great many detail. And if we could get a step further, we would like to have diagnostics. Like, we have the speech, what's wrong? Yeah, that step is difficult, and especially because, yeah, all cancer patient is different, every tumor is different, every treatment is different. So you don't have any data, you have to work with this small group of patients. And more in general, as also talked, we would like to have more speech technology for our patients, pathological patients. Delft University is going that way, as Sungyo will probably know better than I. And then this thing, voice conversion to pathological speech, what Ben's also worked on. Converting speech of patients that speak normally to speech of patients after their treatment when they don't speak normally anymore. That's generating pathological speech. And that's the information, the counseling part of the speech therapist work. There is this discussion, we had this discussion yesterday where, yeah, how do we get the information to the patient about what will happen after treatment? How will they sound? How will they look? Yeah, we can manipulate pictures, so that's doable. The cosmetic surgeons have many tools that can show you how you look after whatever you want to do. But we want to do that for voice too, and for swallowing, but let's forget that. So there is this obvious, the question, do the patients want this? We are studying this. There's Song Daimal, a student, PhD student that is working on what can we show the patients and what do they want to know. As most people don't know how they sound anyway, unless they have been listening to their own recordings, which most people don't do. The first time, we all know that, first time you present someone with his own voice, they say, that's not me, what did you do? We did nothing, this is you. But people come with their relatives, with family, with friends, so they can help understanding what's happening. And you can have, as I said yesterday also, you have to present both before and after so they can hear what's different. We hope that hearing something that is clearly you produced, helps in getting the information, this is me, this will happen to me, it might happen to me. Not like this is happening to him or her, and why should it happen to me? So, and if we have the articulatory movements, if we do articulography and we have the articulatory movements, we have another option to generate pathological speech beyond voice conversion, as Ben's told yesterday. In voice conversion, you do something magical and it happens. And no one knows what happens, actually. But if you have articulatory synthesis, you say, okay, tongue moves this way, sound moves that way, sound changes that way. So if we know that the tongue cannot move this way exactly, but move somewhat different, we can make a sound that corresponds to that different movement more exactly and transparently than if we say, okay, we move this sound to that speaker characteristics. So we would very much like go from articulography recordings, manipulate them to sound. However, that is not a trivial thing to do, I understood. So there's a lot of work still to do to collect data and get a good grip on how sound and articulation correlate. The second benefit would be that if we have a good grip on how articulation relates to speech sound, we can reverse that relation and say, we have the sound, what was the articulation? If we could manage that, we can get rid of these articulographs and have directly managed. However, I have heard this at least as long as I am in this business, and that's pretty long. So I won't hold my breath for that we can solve this inverse problem of articulation, sound to articulation. So what's articulography? That's determine the movements of the articulators directly. How do you do that? You see the picture on the bottom right, where you stick sensors with wires on them, And the gray box is a magnet. So these sensors move in a magnetic field. Moving something, a conductor in a magnetic field gives you voltage, current, so you can follow how they move and reconstruct that. There's a lot of calculations going on behind the scenes. Maybe you can see what's happening. The sound, I've given up on that. But this is more or less what you get if you sing Happy Birthday. You can actually follow what's happening. The main problems are, one, the tongue is just flat, has no marks on it. So you can't say you stick it there. I can say I stick a sensor here exactly between my teeth, front teeth, perfect, every time the same time. Stick it somewhere there, yeah, where, that's no, especially if you cut part of the tongue, then everything changes. So we never know for sure that we have the same spots, the same every time. And if you try to stick a sensor at the back of the tongue, that won't work. It will lead to gagging reflex and everything goes out, and it's a horror. So they used to do it, I heard in the past, but ethical awareness has progressed. So we don't do that anymore. People don't do that anymore. So, and Benza started a project he told about, a former student of us now does a PhD in Groningen in the same place and is doing a prospective study, but has still to start. And we have high hopes, and we hope to be able to report later, much later, about what come out. But that's the state of the art at our department. So conclusions: there are changes after oncological treatment that affect speech. Sorry, forgot to set it on. That's the thing. You say everybody has to silence their phones, and it's your phone that goes on. Impact on speech functioning. We need a multidimensional approach. There's no single measure that will tell us all. And our patients need much more counseling than they can get now. Thank you.
Thank you, Rob, for sharing your perspectives. Yes. Yes. Yeah. Okay, so that brings us to the end of the clinical perspectives, but we have one more presentation before lunch, and it's from Professor Dr. Felix, who's going to talk about the aspects of detecting COVID from voice. And with that, we move to the technology perspectives, and we'll have the other presentations after lunch. So, Felix, are you going to share your slides yourself?
Thanks a lot.
Or do you want me to look for them?
Yeah, I can do that. Can you hear me well?
Can you share them?
Hello?
Yes, yes, we hear you.
I can, yes. You hear me and I can share the slides. Both.
Okay, perfect.
Oh, yes and yes. Okay, so let me share them. Where are they? Here. So thanks for the invite. Happy to be here. First of all, I have to sadly say that I'm not a professor anymore. I finished my professorship at the U Berlin. So it's only Dr. Burkhardt, but that's okay. Aspects of detecting COVID from voice. A practical approach, practical because we are a company and we try to earn money. I guess that's why it's practical. And its work has been mainly done by Uwe, actually. So this is here Uwe Reike. Some of you may know him. He's been to study at LMU and so. All right, here we go. So what did we do? We were interested in correcting perhaps I have to say the company usually does speaker assessments. Our main business is emotion recognition for gaming, stuff like that. And when COVID started about 3 years ago, we were curious whether our technology and our neural net would be able to detect or to separate COVID from non-COVID, not really from having a cold, actually. That's obviously to collect data. There is a special special framework for this that we developed at Audiering. It's called AI Sound Lab, and it's server-based and has an app interface so that we can easily collect data. But yeah, well, it has some features, and we're really developing this also as a product. So this is how this worked. If you were someone dedicating voice samples, then you would fill out these forms here. So obviously you would start whether you have COVID or tested positive or not for Corona, COVID, and then which are your symptoms if you have any. And then you would donate lots of samples, phosphorus and like coughing. And it's the next slide actually. So we asked for mouth breathing, nose breathing, deliberate coughing, laughing, sustained vowels, obviously. So R, E, E, nasal. And counting, so even in the fast way, so to get you out of breath, pataka stuff, and reading 2 sentences, famous Northman and the Sun. So I think most phoneticians know that. All right, so we collected data. We had no funding, so it wasn't very strong. This whole investigation is preliminary in nature. You see, we got almost 10,000 reports, which is not bad, I guess, from 460 speakers. Many of them not knowing, most of them male, but there's also 30% female and 1% diverse. And the age was all over the age groups. I don't have statistics actually on that here. Yeah, that's that. Let's keep this short. We extracted acoustic features with our framework OpenSmile. So this is not about neural nets. This is about expert features. OpenSmile is a framework that extracts about 6,000 features from per frame. No, not per frame, per turn. So we have low-level features, and then we combine them with. And Uwe extracted from this something which he calls mid-level descriptors, or now we call it, I guess, for marketing reasons, biomarkers. So this is high-level features that are extracted on the basis of these OpenSmile features. Something like he detects voiced syllables, so syllable nuclei and stuff like that, which is important, of course. All right, so I would like to show you some select cherry-picked results. I hope you can still hear me. It says my internet connection is unstable. But okay, I continue. So this is one example. You already see 4 bars, negative COVID and positive COVID, and then with symptoms or without. And with respect to the lower alpha ratio, which for the breathing sound through the nose, it was lower for people who were tested Corona positive, COVID positive, and that indicates a less higher energy at high frequencies. So we suppose it might be due to less strong inhalation. Here's another one, coughing. They look pretty similar actually, but it gave a significant difference. So perhaps due to fatigue or throat ache, the speakers with symptoms indicated less strong deliberate coughing. And yeah, there's many more. perhaps. Oh yeah, well, but it's the only thing I say, so that's okay. I seem to go through them. Suitable rate for laughing. So there was slower laughing for COVID, corona patients, and yeah, normal one, I guess, for not corona patients. Sustained A, R, so the larger deviation from the energy contour. So it's based on a regression midline, and then the deviation was stronger if you have corona COVID. And so this indicates less control on subglottal pressure. Possibly. Sustained M, high aspect of spread for COVID when producing sustained sound, and thus indicating lower articulatory stability. Again, nasal sustained N, the utterance initial energy deltas were a bit higher. Again, perhaps due to lower control over subglottal pressure. And I guess one of the last ones, pitch variation for reading. There was less pitch variation, more monotonous speech for the speaker, as you can see here. Interestingly, maybe it's not so important if it's the symptoms or not symptoms. And you see, we have here symptoms also, because I said we don't know if they have corona or a normal cold, but I think if you're corona negative, tested negative, well, you can't be really sure, can you? But then you can have symptoms and not have the corona. So pitch variation for reading deviate less from a common midline, so less melodic speech. Again, I think we had that before. And for Pataka, the intersyllabic variability is more. There's more variability. Goes more over the range if you don't have corona COVID. So there's less rhythmicity for corona patients, which makes sense. So conclusion, so we were able to identify a rather large set of potential vocal biomarkers for COVID-19 assessment. Some were shown here, cherry-picked. So none of these features alone would be sufficient, of course. So we will experiment further with that. And generally, I have to say, of course, we use this in general to find, because we're interested in markers for pathological speech in general. Okay, thanks a lot. And if you have questions, I'm afraid I don't have time later, but yeah, contact me via email or LinkedIn. I'm happy to be contacted.
Okay, thank you, Felix, for your presentation. We all enjoyed it. So now it's time for lunch, and we'll have lunch until 1:15. And then so 1:15 we start again. The ones that are online, enjoy your lunch at home or in your office, and we're going to enjoy beef stew with French fries. So it's
I'm really sorry not to be there.